is having heart failure, preserved ejection fraction. You're supposed to stop one of the therapy, beta blocker. Fine. Because if you see, we'll discuss more on this preserved ejection fraction heart failure, how they are actually thriving. They are thriving because by increasing the heart rate. Because the problem is the stiffness of the heart. Stiffness of the heart, it prevents heart filling. So there, the heart tries to compensate by increasing the heart rate so that the total cardiac output is not reduced. So if you give beta blocker to this group of patient, then they will have issues. So now all the guidelines very clear until the patient is having something very compelling, atrial fibrillation, something like that. You are supposed to stop. So from presentation, it cannot differentiate any of this class of heart failure. So, anybody will present with you similar kind of symptoms. So, what are those key cardinal symptoms? Most common is shortness of breath, and it can be initially on exertion. In advanced stage, it can present during rest in the form of orthopnea, in the form of PND. So we are all aware of PND. So PND, yes, sometimes PND can also be there in preserved ejection fraction heart failure. There, but because many of the patients are nowadays getting admitted because of shortness of breath. So shortness of breath is the most common manifestation, followed by something known as fatigability. Fatigability is often underestimated. Get patient, डॉक्टर साहब अभी बहुत वीक लग रहा है, पहले मैं चलता था 3 steps उठ जाता था, 3 तल्ला उठ जाता था, अभी नहीं उठ पाता हूँ. So that is something you need to give importance because fatigability is another very important presentation of this kind of patient. So these are the two most common presentation. Apart from some group of patient will tell you about the features of volume overload, pedal swelling and all, but these are the commonest presentation. Yes.
Right. Excellent. So excellent opening thing. So I think a couple of things I'll just peel out from what you said. So one is, I think, this in fact a series of sessions we had this learning which is constant, which is great. One, again, a constant learning which you reiterated, that heart failure with preserved ejection fraction is a different beast compared to a heart failure with reduced ejection fraction. These are diseases which are separate. So you have to be treated in a separate way. They have to be dealt with in a separate way. The treatments may be separate, even though the clinical presentation may be similar, right? They are completely different diseases. And I think in that regards, what you said, again, very interesting, is that somebody now, because with effective therapies, somebody with a HFpEF will have an improvement in the ejection fraction. So becomes a heart failure with an improved ejection fraction, which is not the same as a heart failure with a reduced ejection fraction, with a preserved ejection fraction. So a HFpEF and a HFIMEF are different things, right? So I think that again is a very interesting thing. So these are different pathophysiology. And again, another important point, I think this, again, a lot of our audience has been listening to in the previous talks also, that beta blockers, while they're cornerstone in HFpEF, they are something which you generally avoid unless some other compelling reasons in a HFpEF. So I think that again is something which a very important clinical pearl to deal with. We're talking about pathophysiology of heart failure with preserved ejection fraction. And Dr. Pande, what's your take on why do patients develop HFpEF? What exactly leads to HFpEF?
Yeah, so very important. Etiology of HFpEF and HFpEF are completely different. So if you see the overall presentation and the characteristic of the patient, you'll find more presence of comorbidities. Okay. So they are many times very obese individual. They have comorbidities in the form of COPD. Some of them have obstructive sleep apnea. And yes, the other important risk factor, hypertension, diabetes, atrial fibrillation, dyslipidemia, all these things are actually more prevalent preserved ejection fraction. At the same time, the age group of the patient is also higher. So this is literally a disease of the elderly. So why? Because simple. What is heart failure preserved ejection fraction? It is the stiffness of the myocardial muscle, both atrium as well as ventricle. At one point of time, we talked about ventricle only. Now we understand atrium plays a very important role as well. So they become stiff. So why they become stiff? Age is one of the very important risk factor. Apart from that, most of the other conventional risk factor, they are present more frequently, and mostly they are very obese individuals. So these are the basic things we need to look at whenever we are thinking that this particular gentleman or lady might be having heart failure preserved ejection fraction.
Excellent. So important comorbidities, again, very important lessons to learn. I think they said older people, diabetic patients, obese patients, these are the patients you are looking at in terms of heart failure. Okay, again, in terms of diabetes connection, so I think this is a very important. Diabetes forms the cornerstone, and again, this series is supposed to be heart failure and diabetes. So, if you talk about diabetes per se, if you talk about the numbers, it is diabetic male is 3.8 times more likely to have a HFpEF and a female. And so, it's one of the comorbidity, one of the risk factors is being the female sex here. It's more common, 5.5 times in females. And again, very interestingly, the HbA1c also has a direct impact on HFpEF risk, where you have for every 1% increase of HbA1c, there's 8% increased risk of developing a HFpEF. Dr. Pande, this entity, diabetic cardiomyopathy, is it same as HFpEF? What do you understand? Is it still a relevant term in 2025? Should you still use the term diabetic cardiomyopathy? What's your understanding of diabetic
Yeah,
cardiomyopathy?
of course, it is very much established entity. I'll tell you example. I'll give you
Yes.
example.
Yes.
We interventional cardiologists many a time get a call from the physician, endocrinologist, diabetologist. See, during evaluation, a good number of patients they are doing echocardiography.
Right.
So during evaluation, the ejection fraction is low. Otherwise, the patient is asymptomatic. Now, what we are supposed to do? This is a class 1 indication to do a coronary angiography. If you find someone with unexplained LV dysfunction, so they are the patient who are diabetic, having unexplained LV dysfunction, we did angiography. So what we are supposed to get? We are supposed to get some blockage, but you'll be surprised to know that this particular group of patient, good number, good fraction of patient, the coronary angiogram is normal. So what is the problem here? Diabetic cardiomyopathy is an established entity. I'll tell you 3 basic mechanisms why it happens. So in diabetes, particularly in type 2 diabetes, there is something known as glucotoxicity because of very high HbA1c. There is something known as lipotic toxicity due to the typical dyslipidemic pattern. The LDL is normal, but it is the small dense LDL, ApoB is very high triglyceride, low HDL. They cause some toxicity. And third is insulin toxicity. So insulin resistance, insulin is high. That is also not good for your body. So what they do as a whole, they affect a particular portion of the cell is mitochondria. So mitochondrial dysfunction and that cause an array of pathophysiological cascade activation. As a result, patient have clear-cut heart failure symptom. But the issue is it is not always preserved ejection fraction. It can present as reduced, mildly reduced or preserved ejection fraction. It can have any of the morphological representation of the heart failure. So it can happen. So it is not synonymous to preserved ejection fraction, but diabetic cardiomyopathy is an established entity. So how do you prove? So similar to other form of cardiomyopathy, you need to exclude all the other causes. You need to exclude ischemic heart disease because in diabetic individual, ischemic heart disease also a good number of patients because there is a accelerated atherosclerosis. So they might be having MI at a younger age, so ischemic cardiomyopathy. So you need to exclude that. Then there is hypertensive cardiomyopathy. If you see the natural history of type 2 diabetes mellitus, the high blood pressure comes before the blood sugar is getting elevated. Hypertension or high blood pressure is part of the natural history of type 2 diabetes mellitus. So good number of patients will have hypertensive heart failure. So you need to exclude that. So if you exclude all the other causes or etiologies of heart failure and cardiomyopathy, then you are left with something which is nothing other than diabetic cardiomyopathy, and this is established entity nowadays.
Okay, excellent. So I think great points here. So again, moving on. So again, we discussed this risk factors, diabetes, obesity, insulin resistance, all the things Dr. Pande said, hypertension being a risk factor, age being a risk factor. We discussed in the last, before we came here, we're discussing about atrial fibrillation being a very important risk factor. So these are all risk factors associated with diabetic, with a HFpEF. Again, interestingly, again, from an endocrinologist perspective, now we have started doing a sub-classifying of a type 2 diabetes, clustering these people. And there are 2 clusters. You'd all heard about these Swedish clusters from Ellenquist, and some studies were done by Dr. Mohan in India also. There are 2 clusters which tend to have high risk of HFpEF. So one is the severe insulin-resistant diabetes cluster, the third, and then you have the mild age-related diabetes, the MARDs. These are 2 clusters where the prevalence of HFpEF was much higher. When you see these type of patients, with clinical symptoms of dyspnea, with heart failure, you should probably consider checking for the thing. The pathophysiological iterations we already discussed, so we'll be going ahead. And again, in terms of contribution of the systemic and extracardiac complications, pulmonary hypertension, RV dysfunction, microvascular dysfunction, and chronotropic incompetence, we discussed these things. These are also associated with HFpEF. And I think clinical symptoms, Dr. Pande very well said, dyspnea, fatigue, right? And we discussed earlier as well that an unexplained fatigue in a diabetic patient with high risk factors of having a HFpEF is something you should be looking at in terms of potential pathophysiology. So again, these are things you should be looking at. So don't just ignore a fatigue. I think that's something important, right? If you see the suspicion algorithm, age, chronic kidney disease, obesity, hypertension, history of a CAD, atrial fibrillation, these are all associated conditions. Now, let's look at the diagnostic algorithm, right? Dr. Pande, we'll take your inputs here, right? So essentially, from what we understand is NT-proB, so one is of course clinical suspicion and the risk factor evaluation, but you have an NT-proBNP, you have an echocardiography, and you have the HFpEF, or the various types of scoring systems which are available, and finally you do an invasive testing for the diagnosis. So again, generally as a broad outlook, and we'll discuss the individual points, NT-proBNP and the echo, but broadly, what is the typical diagnostic algorithm that you use in your practice for diagnosis of HFpEF?
It's very important to understand. We first need to see the symptom of the patient. We all discuss about the symptom.
Yes.
The heart failure symptom, that has to be there on board. Second thing, what you need, if you are going ahead with reduced ejection fraction heart failure, simple echocardiography is sufficient because you can document the ejection fraction has gone down and the patient is symptomatic, so diagnosis is confirmed. But in preserved ejection fraction heart failure, if you do the echo ejection fraction normal, so there is additional criteria with some form of biomarker, either BNP or NT-proBNP. Mostly we are doing NT-proBNP because that is superior. BNP has some fallacy because some of this group of patients might be on therapy. On ARNI. Yes. So ARNI increases the BNP, so that will have a confounding factor. So better to go with NT-proBNP. Nowadays guidelines also streamlined, so you can easily use NT-proBNP. So NT-proBNP has to be elevated if you want to diagnose anybody with heart failure and preserved ejection fraction. Now, third parameter which is needed is to show some kind of structural abnormality of the heart. It can be the LV mass, which is high. It can be LA volume, which is high. If you can have the body surface area of the patient, body weight, height, etc., you can actually have an index out of it that is more specific. Then you have some tissue Doppler parameters. Now, as I assume, more general kind of people are going to attend this seminar. So it is not prudent to discuss all the detail of the tissue Doppler parameters. Can have one or two. One or two means one parameter is E by E prime. E by E prime is the single most parameter. Everybody can memorize the normal value and all, and that becomes abnormal. It is one of the most commonly validated tissue Doppler parameter. If you get it abnormal, then your structural abnormality criteria is matched. Yes, you can keep on discussing. Nowadays, we have speckle tracking. We have multiple more advanced echocardiographic features where the dysfunction can be picked up at a very early stage, but probably for our day-to-day practice, they are not very relevant. So they are not very relevant. We need to actually come up with very simple three, and as you nicely mentioned, there are different scores. So scores for diagnosis of heart failure, preserved ejection fraction, they are mostly relevant for research purpose, not for day-to-day practice, because none of the cardiologists, none of the heart failure specialists, they are using this scores. You can go ahead, you can measure it, but as I mentioned, you need to memorize few of the echocardiographic parameters, most commonly E by E prime, the LV mass index, LA volume index, and if you find some abnormal tissue Doppler, other parameters or the speckle tracking pattern, then global longitudinal strain, that is another thing which is coming in a big way because they are detecting the problem at a very early stage. A heart to increase the LV mass, to increase the LA volume, it is already late. So global, the strain is something you can detect very early. So that is the advantage. Yes, they are relevant, but probably they are not relevant for practical purpose. So these are the three criteria you need to go ahead, and that is more than sufficient.
Excellent. So clinical suspicion, the NT-proBNP and echo, and specifically in echo, like you very rightly said, if you have to look at one or two parameters, probably look at the E to E prime ratio and the LA size and the LV mass. So these are the important parameters, which again, for physicians listening to this, I think that could be something which could be useful in your practice. So these are the general things. Of course, test radiograph, of course, a little anecdotal, right? Echo and ECGs. Like we said, in terms of the key parameters to measure, we talked about, of course, ejection fraction by definition should be more than 50%, which we know. The pulmonary arterial systolic pressure, we'll talk about that with Dr. Pande. We talked about E by E prime ratio, and the value more than 9 is suggestive, and more than 14 is almost confirmatory of HFpEF. And of course, the LA structure, the LA enlargement, the LV remodeling and hypertrophy, these are all features on echo which are useful. Dr. Pande, what exactly is E by E prime ratio? Again, if you could tell us simply, again, non-cardiologist, what exactly is the E by E prime ratio? And how do I ask my echocardiographer or my cardiologist to say that, yeah, this thing you should be looking at?
So basically, what they want to show, our movement of the mitral valve or tricuspid valve for the matter,
right.
In a non-stiff heart where the muscles are not very stiff, and a stiff heart, their relative movement with the left ventricle is different. So actually, these things are picking up that if your muscle becomes stiff, then how fast your mitral valve moves and how the lateral valve, how the movement is there. So that becomes quite disproportionate. So all these things are actually trying to pick that particular deranged pathophysiological mechanism, which is the basis of heart failure with PJ ejection fraction. Fine. So they are trying to pick these things and only. In different way. That's it, nothing else.
And how important is PSP, pulmonary arterial systolic pressure? Because again, we all that becomes a very important parameter in HFpEF. How important is the PSP?
Yes, this is also very important. Why I'm saying so? Because in a patient who is having recurrent episodes of heart failure, so what will happen at one point of time, the patient will develop pulmonary edema, and recurrent pulmonary edema will give rise to something known as high PA pressure. So that is important. If your patient is having high PA pressure, then probably he is in an advanced stage of heart failure. So that is something we must understand. At the same time, we need to evaluate the pulmonary pathology separately, because many of the pulmonary pathology, as I mentioned in the initial part, that this particular people, they have comorbidities. Some people are having COPD. It's very difficult sometimes to differentiate between COPD and PJ ejection fraction heart failure. Now, someone with a COPD and PJ ejection fraction with high PA pressure and someone with normal PA pressure, the prognosis is completely different. So that is why we need to assess the PA pressure separately, and it will give a prognostic help. And also some of these patients will have therapeutic benefit, because as you all know, some of the SGLT2 inhibitors, they are shown to reduce the PA pressure, vascular resistance. In some group of patients, if after correction of all the problem, if still the PA pressure is high, you can try to use a dedicated therapy to reduce the PA pressure. So those are the advantages we can have actually.
Okay, one question which Dr. Sanjeev has asked: how do you define? So you talked about heart failure with improved ejection fraction. What's the definition for a heart failure with improved ejection fraction? Since you're talking about echo right now. Yeah.
This is very important. Everybody should understand. So initial baseline ejection fraction, if it is less than 40%, and now after some intervention, either pharmacological or some other intervention, the ejection fraction is more than 40, maybe 45, 49, then it will mildly reduced range, or more than 50. So preserved ejection fraction. We are not supposed to term it as preserved ejection fraction heart failure. Why? Because there are, I think, 3-4 trials which has clearly shown the reason the patient had improvement in the ejection fraction, if you hold them, then the ejection fraction will go down in a good significant number of patients, around 50% will again have low ejection fraction. Now, people can argue that what is the problem? If the ejection fraction goes down, I'll start the medicine again, the ejection fraction will come up, but it doesn't happen in practice. If the ejection fraction goes back, then even after starting the pharmacological therapy, or some, say for example, there have been trials with CRT patients, they switched off the CRT and the ejection fraction gone down. Now, after going down, they again switched to the CRT on, the ejection fraction in some group of patients that did not improve. And same is true. If repeat challenge of the same pharmacological therapy may not result in improvement of the ejection fraction. So, this is different. The pathophysiology of preserved and reduced ejection fraction is different. Their therapeutic intervention is also different. So the group of patients who have this definition, who fulfill the definition of heart failure, improved ejection fraction diagnosis, all the therapies has to be continued. That is the very important thing, because otherwise, by definition, the preserved ejection fraction patient may not benefit out of ARNI. But if the patient actually had improved with ejection fraction with ARNI, then if you stop it, then you are not doing a good thing, because
Correct.
RNA is a class 2 indicated molecule in PJ ejection fraction, but it's a class 1 molecule. But in improved ejection fraction, you need to continue RNA. So that is to emphasize this fact. There have been
That's why this difference. Very true. I think great point. I think so. It makes complete sense. So I think that's the thing. So when you're going from a reduced ejection fraction to improvement, that's basically improved. So less than 40% and you improve. That vis-a-vis somebody who's already having EF more than 50% and always has that and has other features of HFpEF. So that's something which we had come to. Of course, we have today, we started a little late, so we'll be skipping on some of the MCQs. And we talked about the HFpEF score. We already discussed this while we're waiting for you to join. So we'll be skipping that as well. And like we discussed, and Dr. Pande, I completely agree with you that these scores are great. We often don't have time in our practice to actually calculate all these scores. But of course, it could be very useful for doctors where, especially when you have diagnostic uncertainty, I think score could be something which could be useful. Now, coming to a more practical issue, right? So you have NT-proBNP levels. There are confusing values. Now, there are some guidelines which say that more than 125 is a one size fits all. There are different values which are now given for atrial fibrillation. There are studies which have shown that if you want to make a HFpEF diagnosis, more than 450 should be our ideal category. What value do you think in a HFpEF is a more appropriate value? And I do understand that the problem with HFpEF, unlike HFrEF, is that this is an emerging area and we're still not very clear in terms of the NT-proBNP cutoffs. But what's your cutoff? Yes.
Yeah, very important. This is very important point. Discuss about the values of NT-proBNP. So whoever is seeing this kind of heart failure patient, they should be very much aware of the fact that NT-proBNP value varies according to the age. A value of 450 may be normal for a person who is more than 75. So you need to take in account age. Here in most of the guideline, it is not mentioned clearly, but you need to understand age is a very important thing, which you, on the basis of that, you need to analyze the NT-proBNP. There are other confounding factors. Atrial fibrillation, it falsely lowers the NT-proBNP. Pregnancy, women, men, sex difference, obesity, body weight, those are important confounding factors. But age is something which you cannot ignore. So yes, most of the cases, if you take an average, a NT-proBNP value of more than 450 in absence of atrial fibrillation or more than 300 in presence of atrial fibrillation is something we consider very much abnormal, and that is the criteria to diagnose someone with ejection fraction heart failure. But at the same time, I'll tell you, up to 1800 NT-proBNP may be normal in a person who is 75 years old. So age is very important.
Right. So confounding factors. So again, unlike HFrEF, where things are more clear, I think here things are a little bit more hazy because age and all the other comorbidities like the obesity also, which reduces NT-proBNP levels, all these things come into account. And sir, as far as diagnosis is concerned, when do you consider invasive testing at all? If you do, of course, it's something which we preserve, leave it till the end. But when do you really consider an invasive testing, if any, when you're suspecting HFpEF and nothing else really works out?
So I'll give you my example. See, I can't remember when I last did it, though it's not that I do not do intervention. In fact, when I finish this seminar, I have to go back to my cath lab to finish the rest of the cases which are lying up. Now, the problem is you have so nice echocardiographic parameters nowadays. If you really have issues, you can send the patient to a center where this is a center of echocardiographic excellence. There are people who are trained in GLS. They do such a nice analysis of all the tissue Doppler parameter. Nowadays, we hardly need invasive hemodynamic assessment. So again, if for the matter of discussion, where you are not sure about the diagnosis, so some issue, some doubt, then you can think about it if you're very much sure. But see, it is little challenging in a society, Indian society, to convince someone to go for an invasive investigation where the therapy actually doesn't change much. Because nowadays, what is the most important therapy for heart failure ejection fraction? SGLT2 inhibitors. In any case, they are finding a new indication every alternate day. So you will find it very difficult to not give this medicine to anybody, rather than, what you are going to achieve else. Invasive hemodynamic, if you confirm someone with PJ ejection, you are not going to achieve. So in true sense, I can't remember when I did it last time, and I don't remember anybody who are known to me have done this.
Right.
Only for
Right.
the discussion, we can keep on going.
Yes, absolutely. Absolutely. So more of theory than practical. And of course, we are discussing the risk, the mimics. So you have cardiomyopathy, valve disease, pericardial disease, RV failure, and all those things which could be potential mimics. Let's come to the management aspect. This is the heart failure. So I think we were in the earlier slides where we discussed that class 1, right, indication, level A evidence is mainly SGLT2 inhibitor, right? So would you agree that and treatment parameters, and we have this one question also from the audience, will come to that. SGLT2 is the primary therapy for HFpEF. Do you agree? And what's your view on that?
I do agree. But as we are discussing, our discussion so far has been so nice. It almost covered all the aspects. You should be very clear about the fact there are two class 1 indicated molecules in terms of therapeutic intervention for heart failure PGR ejection fraction, not one. SGLT2 inhibitor is the one, another one is loop diuretic. Many a time we forget that loop diuretic is also a class 1 indicated molecule. So how to choose your armamentarium? So you need to assess the volume status of the patient. If your patient is volume overloaded, the first thing you need to give, even before SGLT2 inhibitor, is again loop diuretic that is having a class 1 indication, both in preserved, mildly reduced, and reduced ejection fraction. That has to be on board. Otherwise, you cannot improve the symptom of the patient very fast. So that is many a time we forget that this particular gentleman is having, whoever is getting admitted with preserved ejection fraction heart failure,
We are giving diuretic,
volume overloaded. So diuretic has to be on the board. Yes,
Correct.
apart from that, because nowadays there are two trials, that is why SGLT2 inhibitor, both DAPA and EMPA are having positive trials. So they have a class 1 indication with level of evidence A, which is in fact not there in favor of ARNI in reduced ejection fraction heart failure. It's a level of evidence B, because there will be no other trial like paradigm heart failure trial, which is going to happen in future. It's a so nicely conducted trial. It is not needed to have. So because of the fact you need more than one trial to have a level of evidence A. So that is there in SGLT2 inhibitor in heart failure preserved ejection fraction. So yes, I do agree. I personally believe in true heart failure preserved ejection fraction, even ARNI doesn't work. If you see the trials of ARNI, Paragon heart failure trial, so the people, they were sub-analysis. Overall, the trial was negative, but in women and in patients whose ejection fraction was less than 57%, they actually benefited. Now, why it happened? Because some group of patient, because of overlapping etiology, the patient with lower part of the preserved ejection fraction, 40 to 57, 56%, some of them actually mimics more with reduced ejection fraction heart failure.
Right.
So that is why they benefited. Similarly, women, the way we calculate ejection fraction, we do not take account the surface area of the patient. So actually, we are falsely calculating the ejection fraction. So there also the ejection fraction which is showing 55% or 60%, actually that is low. If you take surface area, so that is why in women the sub-analysis showed that ARNI works, but it is not on the basis that it is working on the principle, the basic pathophysiological alteration of preserved ejection fraction. It is not
more
working.
of misclassification of these patients into.
Yes, so they are on the lower side. That is why it has a class 2B indication. Beta blocker, as I mentioned, is contraindicated. Its level of evidence is now, the class of indication is class 3. You need to discontinue a good number of patients. Now, other molecules which are having class 2 indication is the mineralocorticoid.
So we'll come to that, sir. We'll come to that. Right. I'll just take one question, and I think we'll take a comment. So there's a question from my anonymous attendee, which is very right. Our understanding of HFpEF is inadequate. It's heterogeneous, complex. Not even systolic dysfunction is excluded very well. And so to expect a single class of drug to work in all phenotypes is far-fetched. We need to be able to diagnose diastolic heart failure separately from HFpEF, then we'll get better drugs. So I'm sure we all agree with the anonymous attendee that the reason why we're actually discussing HFpEF today is because we understand HFpEF not as well as we understand HFrEF, right? It's still an emerging area of understanding, and completely agree with this point of view that it's an heterogeneous condition. And like you very rightly said, and it's actually an eye-opener, that a lot of these patients actually may have HFrEF or heart failure with improved ejection fraction, which are misclassified as a HFpEF. And again, we are not very sure about that. So I think we'll all agree. But I think one thing which anonymous attendee missed out, I think this one class of drug which does tend to work in everything, is probably SGLT2 inhibitor. So no matter what type of heart failure, what phenotype, subphenotype you're looking at, you're probably dealing with a class which works in all of them, right? So whether it's HFpEF or improved ejection fraction or preserved ejection fraction, all of them, you have class 1 indication for SGLT2, which makes it probably safe to use in all these patients, right? Unless there are certain other contracts. Agree?
Yeah, fully agree.
Absolutely.
Absolutely
Right.
right.
Okay. So I think absolutely. So I think it's a great point and great area of discussion. Very sorry we are skipping the MCQs today. We generally tend to have a little interactive thing, but we'll go on. One more drug, Dr. Pande, which is now also becoming very useful, is the GLP-1RA. I think as time will go, probably now you said we'll have more emerging therapy studies. And unlike Paradigm HF, there are a lot of companies interested in GLP-1RA, where there are going to be a lot of trials, especially in HFpEF also. Now, an early indicator in some of these trials is actually very promising. So again, you have the STEP HFpEF trial, which looked at heart failure, which showed clinical improvement in terms of functional walking capacity, actual clinical improvement with GLP-1RA with semaglutide. So there are now a lot of studies. Tirzepatide also are being studied in this, and there are more emerging GLP-1RA. So I think in future, we might have more role of GLP-1RA. But now let's come to the point which you're discussing about MRA. A little interesting, ambiguous. Can you just clarify this position of MRA HFpEF?
So as of now, if you see the class of indication, it's a class 2B indicated molecule.
Correct.
Now the problem is that, I'll just quote 2 trials. One trial we all are aware of, the TopCat trial, which was done with Electron. Now the problem with TopCat trial, it was such a robust trial, but it failed because of bad representation from some of the countries. So there was huge geographical differences. We still believe some good number of cardiology fraternity, we still believe that mineralocorticoid receptor is a very good medicine for preserved ejection fraction heart failure. Why? Because this is the only group of medicine which has anti-fibrotic capacity. So cardiac remodeling, the stiffness, which is the basis of preserved ejection fraction, only this group of molecule has shown to improve. Atrial fibrillation, even the ARNI failed to show improvement of atrial fibrillation in reduced ejection fraction heart failure, even if that was a robust outcome, but it failed to reduce the prevalence of atrial fibrillation because it do not have this anti-fibrotic activity. Whereas this molecule, this can actually prevent the atrial cardiomyopathy, it can prevent the remodeling, it can have anti-fibrotic efficacy. So TopCat trial, had it been done little more intelligently, would have a first positive trial, which SGLT2 inhibitors are now enjoying. And you can see the newer generation non-steroidal MRA, already the FINARTS trial, it has shown that this molecule works in preserved ejection fraction heart failure. So that was more meticulous, but the problem of patented molecule will not find investors, so robust trial is not going to happen. But finerenone will come with more data. Probably in future it will come in reduced ejection fraction in a big way, but preserved ejection fraction already the data is there. So in future, the class of indication of mineralocorticoid receptor antagonism may change in guidelines. And even if it is changing, we personally believe as the molecule MRA, they should be there on board in majority of the patient with preserved ejection fraction heart failure.
Excellent point, I think, and very important and interesting point that FINHEARTS trial, right, with finerenone, where you have, and very rightly said, structural changes to the heart, the fibrosis is actually reduced with MRA. We already know in kidney, so with finerenone, we already saw that in kidney it actually does the same. The heart also now with these emerging trials, and you're very right. In fact, more classes are emerging in this group also. Non-steroidal MRA is again a very hot class of drugs. A lot of pharmaceutical companies are interested in making more drugs over there, which also shows that there is a lot of untapped potential, especially in HFpEF, right? So I think, I'm sure when we are having this discussion, Dr. Pande, 2 years from now, I'm sure they would have an upgrade to a class 1 indication there as well, I'm sure. Okay, Agni, you talked about the ambiguity. We will discuss all of these in a minute. Beta blocker, you're very clear about it. So there's a little difference in opinion from one of the audience. We'll come to that. And some of the other drugs probably are more of legacy effect. These drugs, ARNIs, ACE inhibitors, and ARBs, beta blocker we already discussed. ARNI, ACE inhibitor, ARBs, where do they stand as far as HFpEF is concerned?
So they are all class 2 indicated, class 2B indicated molecule.
Correct.
But I personally feel if you really want to treat patients for the sake of heart failure control, I would rather choose ARNI over ACE inhibitor and ARB because it is already there. ARB is part of ARNI and it has shown in reduced ejection fraction that heart failure control is far superior with ARNI compared to ACE inhibitor. So if you really want to give, yes, I do prescribe in some group of patients where I feel that nothing else is working. So and more so if they have comorbidities such as hypertension. So hypertension with preserved ejection fraction heart failure, ARNI is a good bet. And future there might be more generation of trial because some unexplored area, resistant hypertension, there the trials are ongoing. And future will tell us that even in it come into the hypertension management in some group of patients. So if we need to look into the comorbidity, associated features, other associated risk factors, then ARNI you can use, yes.
Absolutely. So I think we'll take a couple of questions from the audience. We'll just quickly. So Sanjeev has asked.
Yeah. Just few points regarding the newer, something you mentioned on the right side, nitrate, phosphodiesterone, digoxin, probably none of them are indicated as of now.
Correct.
And all the negative topic agents should be avoided because as I mentioned in the initial part, they maintain the cardiac output by increasing the heart rate, which is actually not bad for them. But one group of medicine in the form of vericiguat, which works very close to phosphodiesterone inhibitor, directly works on the cyclic GMP. As of now, we have very good data in worsening heart failure. So this may also come in preserved ejection fraction heart failure in future. So we need to look into the trial which we are having is Victoria trial, but another trial, Victor trial is underway, which is rather little more stable group of patients. And in future, in preserved ejection fraction heart failure also, this particular molecule, vericiguat, can find some place in therapy. And we should be also clearly understanding that GLP-1 analog, as of now, we have only evidence with injectable semaglutide, not with the oral semaglutide. Now it is available from last 3-4 months in India as well. So if you really want to use it as per the medical legal issue, you cannot use oral. You need to use injectable because the data is there in favor of injectable semaglutide only.
Absolutely. Yeah. So Sanjeev was asking about in the risk of. So now Dr. Pande said, in fact, injectable semaglutide just released in India just a day or two back, and now it's going to be available soon. So you'll have injectables available for use in India. And you have now, of course, CV benefit trial, the SOUL trial with oral semaglutide, but which, of course, looked mainly at myocardial infarction risk reduction rather than heart failure. So again, that's very rightly said. That's where the thing. And again, tirzepatide would also emerge eventually with most robust data on this topic. One of the anonymous attendees, again, beg to differ on beta blocker. I think we discussed this point in detail. So I think we could probably, there's a slight difference in opinion, which is great. I think that's always a good part for debate. But I think probably,
if you want to follow the guideline and recommendation.
Yeah, and again, we are very right. Correct. Correct. So in the guidelines, PEF guidelines, now it's very clear that beta blocker should probably be avoided unless there are some other compelling indications for the same. So I think we'll go with the guideline-based recommendation also. And one more webinar guest has asked, type 2 diabetes, HFpEF, no evidence of kidney disease, which MRA will be preferred, spironolactone or Finderon. I think as far as data, and Dr. Pande rightly said that TopCat trial is a little muddy data, whereas Finderon, Finharts was a more cleaner data. So you had a very good emerging response with Finderon. So I think if cost is not an issue, I'd probably use Finderon again. But if it being an expensive molecule, if cost is an issue, why not use spironolactone? That is what.
Yeah, if you ask my mind, I'll use Finderon. If you ask my heart, I'll use spironolactone.
Yes.
So that way I can.
And if we have to ask the heart, because end of the day, that's what we're treating. Okay, great. Yes, interesting discussion points. I think we are just to the last part of it. Device-based therapies, any role, interventional cardiologist, any intervention has any kind
of now, most of these therapies are actually under research. They are not approved for clinically use. But I can quote you one of the data where empagliflozin was used to also these invasive PA pressure monitors were there, which are available cardiomem devices. And they can they showed that the pulmonary resistance index was very significantly reduced with use of empagliflozin. So that much we are having. But as of now, none of this therapy are approved to be used in clinical practice. If you want to use it, you need to use it as an off-label indication with a direct discussion with the individual who is receiving it. They are mostly research purpose.
Okay, absolutely. So just tide over it. Let's come to take-home messages. And before Dr. Pande gives take-home, I'll just tell you some of the things which I learned from him. One is, of course, very important. I think that's very important take-home message. I think all of you need to keep this in mind. Said HFpEF, HFpEF, and HF improved ejection fraction are different entities. Especially HFpEF and HFrEF are two completely separate entities. We need to be aware of that because their pathophysiology is different, they're structurally they're different, treatment also wise they differ. And one very important clinical pearl I'll take home is that a HFpEF, you need to be very careful that you don't mistaken it for a heart failure with an improved ejection fraction, because again, very rightly said, some of the therapies, especially RD, is something you should continue in a heart failure with improved ejection fraction patients, because it will continue to have benefit in those patients. So I think that's a very important message I learned. Beta blockers, we had also discussed in earlier lectures, also in the earlier cardiologists also were of the opinion that beta blocker should be better avoided unless there are certain other compelling indications. We talked about echo, and you said E by E prime ratio is a very useful, which you get from tissue Doppler imaging, is a very useful tool for diagnosis. Again, echo plays a very important role here because NT-proBNPs tend to be a little muddy as far as the diagnosis is concerned. But again, clinical suspicion is something which is more useful. In terms of treatment, I think the star, of course, is SGLT2 inhibitor. I'm sure irrespective of the phenotype, it works. But as far as the other drugs are concerned, GLP-1RA, emerging therapy, Finrenon is showing good data, and spironolactone, Dr. Pande says, if he listens to his heart, it's still a good drug to use in these cases. And the other drugs are probably sketchy as far as the indication is concerned. So this is what I learned from you. Any take-home messages from your side?
Very nicely summarized. In fact, I will try to summarize in this way. What your mind doesn't know, your eyes doesn't see. Right. So heart failure preserved ejection fraction is something you need to really look for it. Nowadays, though there needs some further modification, more rectification, but as of now, it is in a position that you do have definite criteria. You can jolly well remember that, and you can now diagnose patients who are having this kind of situation. So if you need to think about it, whenever you are dealing this kind of presentation, you need to think about it, then only you can diagnose. And once you diagnose it, then you have very good therapies nowadays which are available. And I can see the future. Future is very nice because more those kind of therapies will be available. So you need to keep this entity in your day-to-day practice. You should not forget. And both for stable patient who are seeing the chamber patient at the same time who are admitting the patient in hospital, it is relevant for both of them. So that's how I should finish it.
I think a great point. So I think great. I think it's a very foggy area. We have, I think, cleared a lot of fog from that. Any word from Dr. Sonkar and Dr. Sameer? Any questions you'd like to ask or any?
Yes, sir. Thank you so much, sir. It was a very nice and interactive session. I just have one question, sir. As you mentioned that beta blockers are given in a compelling factors. So what are those compelling factors? Like atrial fibrillation can be one of those. And if so, what should be the heart rate that need to be kept in these patients? Because as you mentioned, heart rate should be maintained because the pathophysiology for preserved is.
Yeah, so I think what is the compelling indication where you'll use a beta blocker?
So it's very important. So compelling indication of beta blocker uses. One is definitely atrial fibrillation and many other arrhythmia, not only atrial fibrillation. It is effective in a wide array of arrhythmia, and sometimes it becomes very difficult to keep the patient without a beta blocker. Second group of patient will be ischemic heart disease. They are the first line therapy as of now for angina treatment, chronic coronary syndrome treatment, post-MI patient. Post-MI angina, post-bypass surgery, post-angioplasty angina, they are also beta blocker are the first group of patient which has to be there. So these are the three broad criteria classes of indication. Apart from that, you'll find many. Nowadays, there had been enumeration by European Society of Hypertension, 50 indication of beta blocker. So beta blocker, they are now considered the first line therapy for hypertension management. Now, additionally, to stress upon the fact that you need to use beta blocker in high adrenergic diet patients, there has been 50 specific name of the disease. If I keep on enumerating those, that will take a long, but some of them is pregnancy-associated hypertension. So COPD, at one point of time, COPD, bronchial asthma is a contraindication, but COPD also used to be a contraindication. But now we know there are trials which have showed if you use cardioselective beta blocker in COPD patient, the chance of arrhythmia and sudden cardiac death comes down, and it actually improves the survival of the patient. So similarly, there are many more compelling indications, but if you really want to remember the common one, arrhythmia, more particularly supraventricular arrhythmia, atrial fibrillation, ischemia, angina, and the other compelling indications, say for example, pregnancy, COPD and all. So these are the situations where you need to continue using it. Otherwise, for the sake of heart failure treatment only, there is no role if the ejection fraction crosses 50%.
Right. Great.
And second part of the question,
yeah, what target? What would be the
target heart rate? So target heart rate depends on what condition you are treating. So if you are treating a angina patient, they keep very nice. If you can keep the heart rate in between 55 to 60. So similarly, reduced ejection fraction heart failure patient, that is the target of heart rate. But as I mentioned, if the ejection fraction has dropped, so the heart failure indication is not there. Angina, you need low heart rate because you need to monitor the exercise heart rate also. Exercise heart rate is taken care by only beta blocker. Other molecule many times they fail to control exercise induced heart rate increase. But it depends, but high resting heart rate is something which is important and relevant for some of the patient because that indicates a high adrenergic drive. So there also beta blocker comes very early in the management of hypertension. So that may be sometime indication for using beta blocker for the sake of managing hypertension.
Absolutely. I think great points there. Anybody wants to raise, you can just raise your hand. I'll allow you to unmute. Meanwhile, thanks, Dr. Sonkar. Great question. Dr. Sameer, anything you'd like to ask? If he's there. Okay.
Yeah, so I think it was a great session. And again, HFpEF, as I already mentioned before, it's not as frequently discussed as HFrEF. So I think it was a very good session. And as I always emphasize upon throughout this particular webinar series, the delegates are really privileged because they have an endocrinologist who has his perspective, and we have a cardiologist who has his perspective. So I think that's an amalgam of both the sides of the coin, and that's what makes this webinar series great. So if you permit me, Doctor, can I just share my screen so that we can just have the details of the last session?
Yes.
Dr. Akanksha, is my screen visible?
Yeah, we can see it now.
Okay. Thank you very much, Dr. Om and Dr. Arindam Pande. I think it was a great session and lucid deliberations. And this was part 3 of the 4 webinar series. And the last topic is next Wednesday, which is 2nd of July, where we touch upon the management. And we'll have Dr. Om Lakhani and Dr. Neeraj Yadav who would be taking the discussions forward. So thank you very much for your patient hearing. And thank you, Dr. Arindam Pande, for taking out time. I knew you were busy and last minute you could somehow squeeze in and for this session. So thank you very much. And again, thanks to Dr. Om Lakhani, an excellent concept.
Thank you. Thank you, Dr. Sameer. And thank you, Dr. Pande, so much. Thank you so much for sparing your valuable time. I think so. See you soon in Kolkata. Next
it was a privilege for me to participate first time and participating in this, and a concept to me looks wonderful, and I really think that this kind of program will be successful in future in a bigger way. Thank you very